Hi, it's Dr. Osgood, and I'm going to be talking about aneurysmal subarachnoid hemorrhage. This is something we commonly see in the neurocritical care unit and is really important to understand this disease process. We're going to start by talking about what is an aneurysmal subarachnoid hemorrhage and how do we recognize it clinically. We're also going to talk about what is the course and complications that patients have, as well as the management strategies that we can employ to help improve outcome. Aneurysmal subarachnoid hemorrhage is when there is an aneurysm rupture and blood goes into the subarachnoid space around the outside of the brain. The two types of aneurysms we most commonly see are saccular and fusiform. Aneurysms are typically located at the branching points of blood vessels within the circle of Willis of the brain. Most commonly the anterior communicating artery, followed by the middle cerebral artery, and then the posterior communicating artery. It's important for us to understand who is at highest risk for getting a subarachnoid hemorrhage. This typically occurs in the middle-aged population. Patients who are around 55 years old is the mean age. Women also more commonly than men get aneurysmal subarachnoid hemorrhage. Smoking predisposes you to post-aneurysm development as well as subarachnoid hemorrhage. High blood pressure is another risk factor. Family history of aneurysms or aneurysmal subarachnoid hemorrhage is also a risk factor, as well as drug use, particularly cocaine. I'm going to start with a case to kind of take us through the course of aneurysmal subarachnoid hemorrhage and how we should manage these patients. We have a 43-year-old woman with a history of tobacco abuse and hypertension who presents with a severe headache that was initially thought to be migraine. She then presents 24 hours later with worsening neurologic symptoms and concern for aneurysmal subarachnoid hemorrhage. As you can see, this patient has multiple of the factors I told you puts her at risk for aneurysmal subarachnoid hemorrhage. She's a middle-aged woman with a history of smoking and high blood pressure. It's important for us to understand in which patients we should suspect aneurysmal subarachnoid hemorrhage and who should have an initial workup. And the reason that's so important is because this disease process is deadly and dangerous if not recognized quickly. So the presenting signs and symptoms of subarachnoid hemorrhage include a sudden onset, severe, worst headache of your life. This is the type of headache that's different from any headache the patients experience. It's extremely severe, often thunderclap, meaning it happens all at one time. Sometimes at the onset of this headache, there is also a loss of consciousness related to the sudden increase in intracranial pressure. Patients may also have altered mental status or neurologic symptoms following their aneurysmal rupture. Oftentimes, neck pain and neck stiffness accompany this type of headache because of the inflammation caused by the aneurysmal rupture in the blood in the subarachnoid space. Nausea and vomiting may be another presenting sign and symptom that's related to this increase in intracranial pressure. When patients have a constellation of these signs and symptoms, it should be very suspicious that they may be experiencing an aneurysmal subarachnoid hemorrhage, and they should have the appropriate workup. Initially, we're going to do a non-contrast CT scan of the head. This is going to show hyperdensity in a particular location here in the basal cisterns in this star pattern that is very consistent with aneurysmal subarachnoid hemorrhage. It's important to note that if you have a high suspicion for aneurysmal subarachnoid hemorrhage, but the CT scan is negative, you should still do a workup, including a lumbar puncture, to look for bleeding into the subarachnoid space. Once you have identified that the patient has an aneurysmal subarachnoid hemorrhage, you want to go further with a CT angiogram. This is commonly done as the next step, which can show an aneurysm as seen in this red arrow. Following that, most patients will go on to get a 4-vessel angiogram, which is an invasive test looking for more characteristics of that aneurysm and also to potentially treat the aneurysm. So here you can see a basilar tip aneurysm that is quite large. When someone presents with subarachnoid hemorrhage, we also want to grade that subarachnoid hemorrhage. And there are 2 grading scales that we use, the Hunt and Hess and the Modified Fisher scale. The Hunt and Hess scale uses the patient's initial presentation to determine what their risk of mortality is. The higher the grade, the higher their risk of mortality. Our particular patient was confused and drowsy, and so she would be a Hunt and Hess grade 3. The Modified Fisher scale, on the other hand, looks at the imaging to determine what the risk is for vasospasm. Our particular patient had thick subarachnoid hemorrhage as well as interventricular hemorrhage, and so she is a Modified Fisher scale 4. Knowing that the patient has high risk for mortality and is high risk for vasospasm, we need to monitor this patient closely and look for any decline. In our particular patient, she suddenly has a worsening where she requires intubation and she is posturing. Her neuroexam has declined. And we have to figure out what is causing that decline. It's really important to understand the course and complications that come up from an aneurysmal subarachnoid hemorrhage. There are early complications, those things that happen within the first 24 to 48 hours. And then there are late complications, the things that happen after a few days. We're going to start by talking about the early complications. Rebleeding is the most feared complication that can happen to someone with an aneurysmal subarachnoid hemorrhage. Rebleeding increases the mortality and morbidity substantially. It has to be recognized and it has to be prevented at all costs. One of the things that we can do to prevent rebleeding is secure that aneurysm. The sooner we secure the aneurysm, the sooner we can prevent this risk from happening. Securement can happen through coiling or clipping. Our particular patient underwent their angiogram, had this large aneurysm, and had coiling of that aneurysm. If there's going to be a delay in securement, antifibrinolytics like TXA can be useful to prevent rebleeding in a short term. These are not to be used for long term or after securement has taken place. We also need to do blood pressure control. Before the patient is secured, we really want to make sure their blood pressure does not spike up because that could increase their risk of hemorrhage. The blood pressure goal is less than 160 systolic, and we want to maintain that to decrease their rate of rebleeding, but also to allow perfusion of the brain to occur. Seizure prophylaxis is another essential before securement. This prevents the patient from having a seizure, which could increase their risk of rebleeding if it were to occur. The other early complications that you see listed here include hydrocephalus, brain edema, seizures, and Takotsubo's cardiomyopathy. We want to be aware that these things can occur early and to be able to recognize them if the patient has a decline. The things that we can do for hydrocephalus include placement of an external ventricular drain. So if a patient has a decline and on imaging they have worsening hydrocephalus, we can place the drain and we can drain out excess cerebrospinal fluid and we can improve the patient's exam. Patients with subarachnoid hemorrhage can also experience brain edema, especially right after they have their hemorrhage. This brain edema can cause significant brain herniation and worsening of their neurologic exam and can be managed with osmotic agents like mannitol or hypertonic saline. Another complication that can occur is seizures. It's really important for us, if we see a patient have seizures or concern for seizures, that we put them on an anti-seizure medication like Keppra to prevent them from having status epilepticus. Takotsubo's cardiomyopathy is another complication that can happen early on. And while it may not be directly related to neurologic decline, it could cause hemodynamic instability, which is not good for patients with acute brain injury. We want to watch for this by doing EKG, echo, and troponin, and we want to manage it when it occurs. Once the patient has been in the hospital for a few days, we start to get concerned that they could experience these late complications. Delayed cerebral ischemia is one of the most feared complications that can happen next to rebleeding. And this is because it substantially increases the morbidity for that particular patient. The way in which we clinically look for delayed cerebral ischemia is to look at their exam and try to identify vasospasm, because we believe that vasospasm is related to the development of delayed cerebral ischemia. Vasospasm occurs after blood leaks from the aneurysm into the subarachnoid space. The blood vessels can get very narrow, which can decrease perfusion to a part of the brain, thereby causing infarction. For these complications, we want to do very close monitoring. We want neurochecks every hour. We want to look for decline. If we see that the patient is having worsening neurologic function days after their hemorrhage, we want to have a high suspicion that this could be vasospasm related. Transcranial Dopplers can also be done to look for narrowing of the blood vessels. You will see increased velocities as the blood vessel gets more narrowed. And if that is accompanied by a neurologic change, we should have a high suspicion that this patient is having symptomatic vasospasm and needs ongoing intervention. We can also use CT angiogram and angiogram in order to identify vasospasm as well. If we this is just an example of a patient that has vasospasm. So this is an angiogram of our patient when she first presented, and this is the angiogram 7 days later, and you can see that the blood vessels are narrowed in various places, and you are not getting the same perfusion of the brain tissue. When we've identified vasospasm, there are a few things that we can do to help manage this patient. One of the things we do is all patients with aneurysmal subarachnoid hemorrhage get nimodipine. Nimodipine was shown in multiple studies to decrease delayed cerebral ischemia. However, it did not decrease vasospasm. It may have some brain protective effects, and we want to give it to all of our patients. We also want to keep our patients euvolemic. We don't want them to be hypovolemic or get hemodynamic instability, because that could increase their risk of delayed cerebral ischemia. When we have someone that has vasospasm and they become symptomatic with neurologic changes, we want to employ hemodynamic augmentation. This means that we raise their mean arterial pressure in order to increase perfusion of the brain and prevent the cerebral ischemia. Another thing that we can do is intra-arterial treatment, IA treatment. That is when they do an angiogram and they put into the blood vessels a calcium channel blocker like verapamil or milrinone, in order to cause vasodilation and increase perfusion, helping to prevent strokes in the arteries that have vasospasm. Really, when we have someone with aneurysmal subarachnoid hemorrhage, we need to recognize it early and aggressively treat it so that we can help preserve the patient's neurologic function and improve their overall outcome. Thank you.